Hello, I'd like to welcome you to A Healthier You. I'm Larry Macon Jr., pastor at Mount Zion Oakwood Village, and I'm also the co-host of the show It's About You on WKYC Channel 3, where weekly we recognize everyday champions, people in our community that are doing some great things. But this series is about your health. Yes, it's about you, especially during the pandemic. You know, as a community leader, I felt compelled to make sure that we get you the right information about your health so that you can live a healthy lifestyle even during these times. And so I'm partnering with university hospitals to get the word out to the community. And today I'm speaking with one of our distinguished guests who will be here giving us all the information that we need. I'm here with Dr. Kim Fitzgerald of University Hospitals. How you doing, Dr. Fitzgerald?
I'm doing quite well. Thank you for the invite. We're so glad to be with you today as we will discuss health topics that we hope are both relevant to the individuals as they receive this information. A little bit about my background. I'm a native New Yorker, went to college and medical school in New York City, State University of New York at Downstate. Been in Cleveland since 1984 as a board certified urologist. Spent most of my time with Kaiser Permanente, and have been at University Hospital for approximately 4 years. So we have dealt a lot with illnesses and sicknesses and diseases that affect the community, and for my specialty, especially prostate cancer. So we're glad to answer any questions you might have, or if you just want a more open dialogue concerning it. I do this every day.
Great. That's good to hear, and I'm sure our viewers are really excited to hear what you have to say. And so we're going to talk about prostate cancer. That is our subject today, Dr. Fitzgerald. But I want to start with this COVID-19 pandemic. I know you have some thoughts and some things to help people, and also to help our churches and also our congregations and our leaders during this pandemic. So give us your thoughts on our current status with this pandemic.
I have been following this from the very beginning, and I've had a chance to speak to many church groups concerning the COVID-19. If there's some takeaways we would like for churches to know, is basically stay in contact with your local health officials, because each state, even each county, can be different and may have different diagrams, different dialogues going on. The second thing we would say is make sure that we understand the basic health concepts for our churches gathering together. Mm-hmm. Number one is the masking. Cannot express how important that is. Number two, the social distancing. Whereas before, you know, in church, we like to hug one another and get close and say, right now,
we're putting that on hold right now.
We're putting that on hold. We're doing some fist bumps, praying for people from a distance, elbows, and things along those lines, elbows, and things like that. Many of our churches, if not most of the churches I'm familiar with, are taking the temperatures of people who are coming in, mm-hmm. and having the hand sanitizers placed strategically throughout the congregation. We think if you follow the basic guidelines of the CDC, mm-hmm. The congregation should stay safe. In Ohio, some churches did close, but many churches didn't close. They just ratcheted the numbers down, protected the elderly, those with comorbid problems, heart disease, kidney disease, lung problems, over 60 years of age, either told them to stay at home, or if they were going to come back under the strictest guidelines. I think if we can do that, we will keep our churches as safe as possible. And of course, prayer is always at the forefront.
That's right. And I've noticed that even within my own church, that we've been able to stay safe by, like you said, following the guidelines, moving forward responsibly. But the great thing is we're still able to worship. We just have to do it in a different way. And we've been successful by following those same guidelines that you're giving. And I behoove any pastors or leaders or any congregants that are here to, in their church, to practice those things that Dr. Fitzgerald said, and you should be okay.
Absolutely.
So Dr. Fitzgerald, let's get into our topic for today. We're going to talk about prostate cancer. What is prostate cancer?
Well, the prostate gland is a gland that sits at the base of the bladder. So when your bladder gets full and you go to empty your bladder out, the urine has to pass through the prostate. And the best way to visualize it is to think of going through a tunnel if you're driving through Pennsylvania or West Virginia. Mm-hmm. The mountain that the tunnel is going through would be the prostate. Okay. And then the tunnel itself would be the urethra where the urine passes through. Mm-hmm. Well, sometimes that mountain can go through certain kinds of changes, which could be detrimental to the individual. Prostate cancer is the third most diagnosed cancer in our nation. Number
Wow.
1 being breast cancer, number 2 being lung cancer, and number 3 being prostate cancer. And then number 4 would be colon cancer. It is not the third leading cause of death. It falls down to around number 4 for that, because although it is prevalent, it is not necessarily that deadly if we can catch it early in certain forms.
Wow. How do we detect prostate cancer? How do we find it?
In the old days, when I was first starting out in the 80s, we could only detect it really with a rectal examination where we feel the prostate with our finger. We also would discover it when men had prostate surgery and we cut the prostate out, think of kind of chipping away at the mountain to make the tunnel bigger. We would find that those rocks that we chipped out had cancer in it. So that was a second way. And then we had a test that was called prostatic phosphatate, alkaline phosphatate. And that test only detected it when it was almost spread and it was too late. But fortunately, we have a test today called the PSA, prostate specific antigen. And that blood test is very accurate, at least in getting us to look for prostate cancer. And because it is prevalent in looking for it, we do find it. And some of the controversies recently is who gets a PSA, who doesn't get a PSA. And we'll get into that in just a minute.
So what are some of the treatment options when you have it or when it's detected?
Okay, what we'll do is we'll back it up and kind of roll into that question. The question is whether we're going to even look for prostate cancer. That's been the big thing since 2012. And the reason why is that prostate cancer, of the men who have prostate cancer diagnosed 5 years ago, 98% of them are still alive today. And most of them without any kind of symptoms or signs or any types of problems. So it's a prevalent cancer. And as one gets older, the chances of one getting the cancer is higher. However, the chance of one dying from it goes down. Heart disease, diabetes, kidney failures, other cancers are more likely to impede your longevity than prostate cancer itself. Now, once we get this PSA test drawn and it's in a higher range, the normal range is 0 to 4.0, then the doctors will begin to discuss with the patient whether they want us to look for prostate cancer or not. That may depend on the patient's age or their condition. What are other more comorbid issues that are going on? Do they have diabetes? Are they just getting out of an ICU? What are things that are happening there? We have other tests besides just a PSA to try to refine who we do the PSA on and how we interpret it. And let me give you a couple of examples.
Okay.
We have a test called a DNA study called the EPI test, where we can take the first urine sample that's given after 2 or 3 hours, and they can actually do genetic studies on that urine and tell us if there's a high risk of prostate cancer or prostate cancer that would be bothersome to the patient. This is actually an amazing study that's been out over the last couple of years. And what we find is a 93% accuracy rate in detecting whether there needs to even be a biopsy to detect it. So we're finding many physicians are doing today is they're not even doing a biopsy if that test is negative. So imagine what you have. You have an elevated PSA, let's say it's 5.0. Let's say you're in your late 60s. You're not sure if you want to go through some of the treatment options we're going to discuss. So the doctor says, well, just bring us a urine sample. We'll test it. And the testing comes back, well, there's a 93% chance that you do not have an aggressive form of prostate cancer that will be of any bother to you. That's an amazing study. Yeah. And we are beginning to utilize that more and more. The second test that I like individuals to know about that has been refined over the last few years is what we call the MRI, the magnetic resonance imaging. They can do imaging now of the prostate, and we have certain categories which we call PIRADS, which can tell us by how it looks. Think of taking a snapshot of a wall and you see little stains on the wall. Well, by seeing different staining in different areas, we can tell you if there's a high chance or low chance that there is a aggressive type of prostate cancer. We're not as worried as much about the low aggressive, the non-aggressive type of prostate cancer. Those are ones which you can follow, and that will lead me to our treatment options. I always tell my patients I got 5 fingers, so I should have 5 treatment options for
Wow.
you. Okay, number one is what we call active surveillance. And
Okay.
that's where we have a very small amount of prostate cancer detected in the biopsy specimens. And it's not of an aggressive nature. It's kind of a slow growing type of version of the cancer. In this particular case, the doctor and the patient may say, you know what, doc, I don't want to go through all the treatment options. I got other things on my plate. As long as we believe it's slow growing, how about we just keep an eye on it? And a doctor may choose to just simply repeat the PSA at certain intervals. He may decide a year or 6 months later to repeat a biopsy to make sure that there are no aggressive elements that are coming into that situation. Or he may choose to simply go ahead and go ahead forward with some treatment depending on what the other tests show, or use that MRI, or use the Exodus tests, the DNA testing in the urine to see if that would be helpful. That's number one. Number two is, well, if you got cancer in an organ, then you cut that organ out. And that would be surgery, and we would call that radical surgery. And it's very important for those who are listening today to understand there's a big difference between surgery that we do for an enlarged prostate to help a man empty his bladder better and prostate cancer. I want you to think of that mountain scenario that I gave you. When we're trying to get a gentleman to empty his bladder better, what we're doing is we're simply making the tunnel wider. So we're putting backhoes in there, and we're chipping away to make the tunnel twice as large or 3 times as large. So what we're doing there is that's a resection where you're leaving the core of the mountain. The mountain's still remaining, but you've made the tunnel bigger. That's what you do for benign disease. However, when we're talking about cancer, you're removing the entire mountain. That whole mountain has got to come out. In other words, the entire prostate has to come out. And that's called radical prostatectomy. And they can do that in a number of ways, technically speaking. So that's the second way of treating.
Okay.
Now, the third and fourth way of treating, I'm going to put it under one umbrella, but it's very important to understand that there are 2 different ways of this treatment is administered. And that's why we're calling it 3 and 4. And that's radiation therapy. And radiation therapy is where you're going to shoot radiation at the cancer. So when the cancer tries to divide, because its DNA structure has been damaged, it dies. So it kind of divides and dies. Now, there are 2 ways in which we can administer radiation. And the best way to think of it is I have a flashlight in my hand, and that's the energy source of the light. And I'm going to shine the flashlight at the individual who has the prostate cancer. Well, in that case, Pastor Larry, the source of the radiation is outside of your body, and we're radiating it into your body. And that's called external beam radiation. Okay. That's been around for seemingly forever. It is an effective form of treatment, and people can usually kind of work through that many times. They may get like a skin tan, like a burn, like a sunburn. Sometimes they may have a little bit of loose stools in the beginning of it, and then occasionally they may have frequency of urination. But that's well tolerated. I mean, for those who are elderly, who've been discovered to have prostate cancer, that may be the one with the least side effects. Now, the second form of radiation, or the fourth thing on the listing that I have, would be where we take radioactive seeds and we're actually going to plant them in you. So I'm taking seeds that are like staples, and I'm actually putting them into your prostate. And the best way to think of this is think of a branding iron. You take the branding iron out of the fire, and what color is the iron? It's orange. Why? Because it has all this heat in it. The energy source is high. But as you wave the iron around, its heat dissipates, and after you can actually touch it after a while, because it's no longer, the energy is not being expanded or expended anymore. Well, these seeds that we put in, which may be 80 or 100 or 90 of them, they're equally dispersed by a radiation oncologist. These seeds are radioactive when we put them in you. And they stay radioactive for about 16 to 18 months. Oh, wow. And then they dissipate. But what they're doing is all the while they're there, and that radiation is killing those cancer cells as those cancer cells are trying to multiply and divide and multiply, then they die. And that's going to have a high effective rate also.
Wow.
Now, the fifth form of treatment, I only mention it just to mention it because people on the internet, they come to see me and say, Dr. Fitzgerald, take care of me. But I know they've been reading everything out there,
Yeah.
even some quack stuff. So I always have to talk to them about some things which they most likely read. And that's freezing the prostate. That's called cryosurgery.
Yes.
And there have been some institutions. It's not so popular in Cleveland. I don't think it really should be that popular in many places, but that's trying to freeze the prostate, but we really don't do that. If you go to the cdc.gov, which is the Disease Control Center, if you go to them, you'll see on their website that they don't mention even the freezing part on that. Right. So those are the forms of treatment that are available.
Would you say one is better than the others? Is there one that's the top treatment, or are they just all different options based upon where you are?
We had pushed surgery. Maybe that's because urologists are surgeons for a long time. But recent studies and recent committees that got together said of the 3 treatments, we're actually doing something on the patient, they come out to be about equal. Okay. But what we need to understand, Pastor Larry, and it's very important for the hearer to understand, there's treatments and then there's side effects.
Yes.
So although the treatments, and we're talking about cure rate, they're cured, or they're going to, this cancer is not going to catch up with them. Although that may be pretty even across the board, side effects can be different. For example, when you're doing radical surgery, you do increase the rate of erectile dysfunction. Okay. You do increase the rate of urinary incontinence. And then you have just anything that can happen from surgeries, pneumonias, pulmonary embolism, blood clotting. These are real things that can occur that the doctor needs to have dialogue. Yeah. External beam, not so much. If you're having problems with the external beam, which is given over several weeks, they can just simply turn the machine off, let you recover for a week from the skin tan or the skin burn that you have or the loose stools, and then they can go right at the radiation again. Gotcha. Now, the seeds is very interesting. I just put 100 seeds in you. How do I get it out if you have a problem? The answer is we don't. You got to kind of live through that one till those go off. Now, it's not usually we're not seeing that problem like we saw in the old days, but those are issues. So we have to think, and it's very important for those who may be having this discussion with their physician, what are the side effects?
Yeah. Gotcha. Now tell me this, is prostate cancer preventable? How can you prevent it from happening? Is there practices you can do or a way to live to, lessen,
Well, we had a saying, and that's called heart healthy is prostate healthy. So anything that you can do to help with your heart rate, the nutrition, the exercise, anything that can help in that area would be helpful. As a matter of fact, we had a study done in one of the institutions I used to belong to, the 2-mile walk. If I could get everyone in your congregation who can walk 2 miles a day, walk 2 miles, it's a radically transformed, health-wise congregation. It helped in mental illnesses. It helped with all forms of cancer. It helped with just about all forms of cancer. It helped people going through cancer treatment, how they recovered, how they tolerated the treatment, and we were quite specific. It was 2 miles per day. It can even be divided up into like 2, like 1 mile, then another mile in the evening, etc. But I cannot express, and if you kind of look at that on the websites, you'll see the 2-mile walk. You see people jogging and lifting weights and doing all that. No, 2-mile walk can work wonders really for anyone who's able to do that. Some can't walk 2 miles, we understand that, but getting up, moving those legs and doing as the good Lord did, walking from place to place.
There you go.
that can have unbelievable health benefits, especially in our sedentary society.
Well, listen, I'm going to stop right there, Dr. Fitzgerald, because I believe that is the most important thing that you ended up with is taking care of your health.
Yes.
Take care of your health. Take care of your body. Take care of this, what we call our temple.
Yes.
We lessen the risks that we have. So, Dr. Fitzgerald, I really appreciate you giving us an update on COVID-19, but also on your insight on prostate cancer. And I want to also thank our viewers for tuning in and watching as you're expanding your knowledge when it comes to health. And so I want to let you know that you can find out more by going on to social media, and we'll post these videos where you can see about your health and about doing better in your life. And also make sure you contact me or visit my website at larrymaconjr.com, and you'll see more videos just like this, again, as I just mentioned. But also go to university hospitals. Make sure that you get checked up. See Dr. Fitzgerald. Call his office. He'll be more than welcome to see you and to help you through your health ailments. Dr. Fitzgerald, thank you again for what you do in our community, and thank you for making people well and also giving them the knowledge that they need to continue to live healthy and more prosperous lives.
Thank you for giving me this opportunity.
Thank you. And don't forget, good health is good wealth. We'll see you on the next segment.
Okay.